Welcome everyone to the class of trauma from occlusion. Before going in detail about this, I want all of you to know about what is occlusion. Occlusion is the relation, you all know about occlusion. This is just a relationship between the occlusal surfaces of the maxillary and mandibular teeth when they are in contact. So when these upper and lower teeth in contact, certain forces are generated. They are the occlusal forces or the biting forces. These forces first transmitted to the alveolar bone. This is a alveolar bone. So these forces first transmitted to the alveolar bone, which are later dispersed to the basal bone of the maxilla and the mandible. And we will see about the adaptive capacity of the periodontium to the occlusal forces. In this case, actually when some forces applied, some hard biting or anything, such kind of forces applied onto the tooth surface, the periodontium definitely will try to adapt itself. And if the amount of forces exceed the adaptive capacity of the periodontium, then the injury occur, periodontal injury occur. And certain factors are there which on which the adaptive capacity of the periodontium depends upon. First is the magnitude. When the forces increased, there are two changes are occurring. One is the changes in the periodontal ligament, and the other change is in the alveolar bone. So these are the two classic changes that occur when a excessive force applied onto the tooth surface. In the periodontal ligament, we can see the thickening, and first we can see the thickening of the periodontal ligament space, and also the increase in the width of the periodontal ligament fibers. And also in the case of alveolar bone, we can see the increase in the density of the alveolar bone. Next is the direction. Actually, the periodontium can accommodate the occlusal forces that occur on the vertically on the long axis of along with the long axis of the tooth. So if there is any changes in the direction of occlusal forces, then this injury occur. Next is the duration. If constant pressure apply on the tooth surface, then that is more injurious compared to the intermittent forces. In example of the intermittent force is the orthodontic. When the patient is taking the orthodontic treatment, we know the force is the intermittent force. So in such case, we can see the areas of bone resorption, and some areas we can see the bone resorption, other area we can see the bone formation. So this is the duration. And next is the frequency. And more the frequency of forces which are applied onto the tooth, then it is more injurious to the periodontium. Next we will see the Glickman's definition of trauma from occlusion. That means when the occlusal forces exceed the adaptive capacity of the tissues, because tissue has a certain capacity to overcome these forces. But when the occlusal force exceed the adaptive capacity of the tissues, then the injury occur, and this injury is termed as the trauma from occlusion or traumatic occlusion or whatever. And next is the classification. First one is based on the onset and duration. First one is acute. Acute means we know it occurs suddenly. Okay? No gradual thing is happening. Sudden situations. In that case, we call as acute. So because of the abrupt change in the occlusal forces, like if we bite something hard, or faulty restorations, or sometimes we can see if we done the restoration, some kind of high points or something would be there on their mouth. So when they bite on that high point, definitely injury can happen. See, if they bite that for a longer period of time means more than 24 hours or something like that, then the acute trauma can occur to the periodontium. Whereas chronic means it's a gradual change. the gradual change which are produced on the periodontium. For example, if someone has a habit of clenching, we call that as bruxism. If that habit of clenching their teeth all the night, or drifting movements or extrusions or other parafunctional habits, because of these gradual changes are happening into the periodontium, so in such case we call this as chronic. Then based on the cause, it is divided into primary, secondary and combined. Primary means the height of the periodontium is normal, nothing has happened to the periodontium is not weak and everything is super fine. In that case, if I just told you now, if a faulty restoration or high points or anything sudden force is applied onto the tooth surface, this is known as this is called primary traumatic occlusion. Whereas secondary means already the periodontium is weak, the height of the periodontium is less and attachment loss is there, a lot of periodontal destruction has already happened in their mouth. In such case, if the normal force is also too much for them, so periodontium is already reduced and occlusal forces are not heavy, just the normal occlusal force, in such case secondary traumatic occlusion can occur. And the combination combined means it's more dangerous. That means both are there, already the periodontium is weak, the height of the periodontium is less, above that more force is applied onto the tooth surface, so these combination traumatic occlusion is actually more dangerous, it is difficult to treat. And next is we will discuss about the signs and symptoms of the traumatic occlusion. It is divided into clinically we can see some signs, and radiographically we can see some evidence. Clinically we can see the mobility. That is a classic sign of the traumatic occlusion. That means the tooth would be definitely mobile because the occlusal force is that much, so the periodontium cannot be able to withstand and the tooth is going to loosen. So mobility definitely would be there. Because of that, pain on chewing or percussion, and you all know about Fremitus test, that test would be positive. Then occlusal discrepancies, where facets, tooth migration, chipped or fractured tooth, thermal sensitivity, these all can be seen on the mouth of a patient with the traumatic occlusion. And in radiographically we can see some evidence that the increased width of the pedial space, this is really important, the pedial space definitely would be damaged. That means if this is the tooth and see if this is the pedial space, if this is a normal case, whereas in the case of traumatic occlusion these width would be more. See, these width would be more. The periodontal ligament space, the width of the periodontal ligament space would be more, and the thickening of the laminal dura. And the other major classic evidence we can see is the vertical or angular bone loss. The horizontal bone loss would be like this, but the vertical bone loss is like this. If this is the tooth, then this is the angular or vertical bone loss, this is the horizontal bone loss. In the case of traumatic occlusion you can see this case, but the pocket formation would not be there. In other cases like periodontitis or any other case, we can see the pocket formation also, but this case there is no pocket formation, the pocket is absolutely fine, but the angular or vertical bone loss occur. Next, we have to discuss about the histologic changes. It is divided into 3 stages. First is injury, repair and remodeling. Injury means I just told you now, when the force is more and the periodontium is not able to withstand, then some changes in the pedial and alveolar bone occur. Next is the repair. When the force is applied and bone is resorbed, there is an attempt to reinforce the thinning of trabeculae, and this attempt to compensate for the lost bone is called as a buttressing bone formation. Remodeling means if the repair cannot keep in pace with the destruction which is occurring from the occlusion, then the periodontium has no other way but it has to remodel itself. So this happens by the thickening of the PDL, formation of angular or vertical defects, increase in vascularity and the tooth mobility. So then next we will discuss about the we will answer some of the questions. First is, after the elimination of occlusal trauma, even in the presence of inflammation, which of the following is most likely to result? Here the inflammation is there still present, but the occlusal trauma got eliminated. In such case we can see the reduction in the tooth mobility, because mobility was the major concern in that case. So if we remove the occlusal trauma, the mobility get reduced, not the regeneration of the PDL or restoration of alveolar bond. The clinical attachment is not going to gain back. So this is the answer. Next is, what is the most common manifestation of occlusal trauma? That is tooth mobility. I discussed, because pocket is not going to occur in this case, recession is not happening in this case, so the tooth mobility is the answer. Then earlier sign of traumatic occlusion is definitely the widening of the periodontal ligament. This is the periodontal ligament. You can see the widening of the periodontal ligament space. And which of the following is not a sign of occlusal trauma? Is the gingival recession, because Fremitus test is positive, widening of the PDL is there, migration is occurring, and then gingival recession cannot be happening in this case. Next we will discuss about, the other question is the trauma from occlusion initiates definitely periodontitis, because gingivitis has no role in this case, so it directly initiates the periodontitis. Then a clenching habit may be a factor in tooth mobility, because of the clenching habit. Pocket is, because no bacterial inflammation or nothing is there, so periodontal pocket is not going to happen, and gingivitis is not the answer. Periodontium is getting weakened, so increase in tooth mobility. All of the following are signs of occlusal trauma, except mobility is there, sensitivity can occur, PDL space can widen, but loss of pulp vitality is not the that will not occur, so that is not the answer. And mobility of teeth without loss of bone support is primary occlusal trauma. Here the periodontium would be normal height of the periodontium can be seen in this primary trauma. Then next is, the arrangement and character of the principal fibers of PDL are modified by occlusal function. Then the periodontium is best able to tolerate forces directed to a tooth vertically, not the other way. And trauma from occlusion may initiate definitely periodontitis. So this is I hope you all are clear about this topic. Thank you.